Hey class. So I hope that everybody can hear this video okay. We're going to be lecturing over chapters 11 through 15. So this is a lot about safety, about falls, and then just a little bit about some bed making and things like that. So we're going to start with talking about falls. So you guys remember when we were talking about our geriatric population, there are two things that we are always concerned with, and this is skin and falls. Falls are something that are very common incidents in nursing homes. And when we're talking about falls, we're talking about ways to prevent them, and we're talking about what causes them. So there are obviously several different things that can increase a patient's risk for falls. And those are going to include things like being incontinent. So your patient has an accident in their brief, they voided, and now they are wet, and instead of lying in bed waiting for you to come and get them, they end up trying to walk to the bathroom themselves. Or, on the other hand, they are continent, and that person feels an urgency, so when they have to go, they have to go, and they do not wait for you to answer the call light, and they just hurry up and try to take themselves, and that leads to a fall. Both of these problems can be eliminated or at least decreased by answering call lights quickly, especially when we know that we have a patient that is incontinent, or maybe a patient that we know attempts to walk by themselves. The biggest thing that we're going to do to prevent falls, and we'll talk about this in class when we start transferring our patients, is to make sure that before we would ever get them out of bed, that we always have on either shoes or non-skid socks. Okay, so footwear is super important. That's the first thing we look at when we go to get a resident out of bed or out of their wheelchair. There is a certain time that falls are more likely to happen, and it's pretty obvious when you think about it. That's always going to be at shift change, because at shift change, where are all of our nurses and our aides? They are at the nurses station. So shift change is when we really need to make sure we've got somebody on the floor and answering those call lights quickly. So shift change, checking our residents' feet before we go to stand them up. And what do we do when somebody falls is another big part of that. So whether the fall is witnessed or not. So sometimes a patient will fall and we are in that room with them. Sometimes we are physically holding them up or walking with them, ambulating them, and they will fall. When that happens, that's called an assisted fall. So sometimes we may be won't witness the fall, and we're just walking towards or walking past our patient's room and we find them in the floor. So when this happens, there are a couple things that you guys need to do as aides. The first thing is we don't want that patient to get up. So if our patient is in the floor, we need to be down in the floor with them. We don't ever want to stand over them, looking down at them, telling them not to move. We want to physically sit in the floor with them and try to keep them calm until the nurse comes. The other thing that we need to do is immediately call for the nurse. So we can press that call light, we can yell out whatever we need to do, but get the nurse in there. Once she comes in, then she is going to perform a complete skin assessment to make sure that there was no injuries that we don't see right off. And then, of course, we're going to need a full set of vital signs, and that will be your responsibility to get those. So we'll get a full set of vital signs. We are going to stay in the floor, make sure the patient is okay. We are not going to get them up and move them until the nurses came in and completed that skin assessment. Then we can get them, with the help of the nurse or whoever's going to help us, we can get them out of bed. Or out of the floor. So elimination needs a big risk for falls. Confusion, obviously a big risk for falls. when we have side rails, when we have a patient that maybe has side rails on their bed, that can also put them at a bigger risk for falls. So let's talk about side rails. You guys know that anytime we leave a room, our side rails need to be down, and that is 100% of the case, always the truth, except if we have a patient who has been care planned, so they have an order from the doctor to leave those side rails on their bed. If they have an order from the doctor, then those side rails are no longer considered a restraint. Most patients in a nursing home do not have those orders, but it is possible that the doctor sees fit for, maybe if they had hip surgery, they need those side rails to help pull themselves up or anything like that, the doctor can write that order. That leads us into our next topic that we need to talk about, and that is restraints. Restraints are a huge topic for not only this test, but your state test. They're a very big deal when you start working. Now, restraints are not allowed at all in nursing homes. If you have a patient that would need to be restrained, that patient would have to be sent out to the hospital. If you work at a hospital, then you have to go through a whole class once you start to learn how to properly administer those restraints. So even though we don't use them in nursing homes, they're still a big topic that we have to be educated on. So there's a couple numbers when it comes to restraints that you guys have to know. That first number is 2. So every 2 hours when my patient is in restraints, I have to remove those restraints. Okay, so I'm going to go in, I'm going to take off the restraints, whether they are wrist, a chest restraint, whatever it might be. I'm going to take them off, let my patient either go to the bathroom or just kind of readjust themselves and get comfortable. And then I'm going to put them back on. So that's every 2 hours that your restraints come off. Every 15 minutes, we are checking eye to eye, looking at that patient and charting on them. Every 15 minutes when they are in restraints. So every 2 hours they come off. Every 15 minutes I'm checking on this patient. When the nurse calls the doctor to get an order for restraints, because we have to have a doctor's order, that order is going to only be good for 24 hours. So if I have a patient that I've put in restraints that is having behavioral issues or pulling out their IV or whatever it may be, if they continue to need those the next day, the nurse is going to have to call the doctor again and get another order for those. So when that nurse does call the doctor, the doctor is going to want to know a couple things. A, why do we need restraints? And B, what type of restraint alternatives have we used? So restraint alternatives are something that we will find in our patient's care plan. There's something specific to that patient. When you think about restraint alternatives, I always kind of think about like a toddler throwing a temper tantrum. What are you going to hurry up and try to get for them to calm them down or to alleviate their anger or whatever it might be? So it can be something as simple as a television show. It can be getting that patient up and taking them for a walk. It can be giving them a snack, maybe just readjusting them. Sometimes there's certain music that will calm our patients down. And it's going to be, again, different and specific for everybody, for each patient. So when that nurse calls the doctor and says, hey, this patient is going to need restraints for his safety, we have tried turning on a television show, we've tried to take them for a walk, I am attempted to assist them to go to activities, nothing's working, we need restraints. So now we've got that order and we can put the restraints on them for 24 hours. The biggest restraint alternative used in a hospital is going to be what we call a one-on-one. So remember that 15 minutes that we need to be looking at our patient and checking on our patient. If we have a patient that every 15 minutes I have to be in their room looking at them and charting, it doesn't leave me much room or much time to do anything else with my shift. So what will normally happen if we can use this instead of restraints is we will assign one person, so one nurse's aide or one nurse to that one patient, and they will just sit with them in their room next to their bed all day. In that way, when they're going to pull at their restraint, or maybe it's a patient that is continually trying to get out of bed and we know that they can't get up on their own because there's such a big fall risk, we have somebody in there to say, hey, let me help you, or hey, let me sit you down, or hey, you don't want to grab that. That is used the most often because, again, if every 15 minutes I'm checking on this patient anyways, I might as well just stay in their room for the whole shift because I'm not getting much else done. When we order restraints, the nurse will decide what type of restraints are going to be best for this patient, and we always want to go with the least restrictive. So obviously if I have a tiny old lady that I'm trying to give blood to, and she's pulling out her IV, I don't need to put her in a full chest restraint, right? I can just put her in soft wrist restraints. On the other hand, if I have a belligerent, maybe he's drunk, maybe he's intoxicated, we don't know, large male trying to kill the entire unit, we're not going to use wrist restraints on him. We're going to have to use something a little bit more. So he might be somebody that we've got a chest restraint on in bed. So it's just going to be whatever is the least restrictive. Now, my patients do not have to be lying down for me to put them in a restraint. They can be in a chair, they can be in a wheelchair. However we position them is fine as long as they are in good alignment and they are comfortable, and I'm not putting them at risk for any type of sores or anything. When I'm doing these 15-minute checks on my patient, again, depending on what type of restraint is going to dictate what I need to be focused on and charting on. So if I have a patient in wrist restraints, then every 15 minutes I need to be making sure that their pulses are still good, their radial pulse. I need to make sure that they still have good circulation, their hands are pink and warm. If maybe it's a patient in chest restraints, obviously I need to be checking on their breathing. Are their respirations normal? Do I have that restraint too tight that maybe it is restricting them a little bit or making breathing difficult? Remember that if we have bed rails up for a patient and they do not have that order, then that is also considered a restraint. The other thing that we need to know about restraints is that we always are going to have informed consent. So obviously if I have a patient, a large belligerent, whoever, trying to kill the entire unit, they're not going to sign a paper so that I can restrain them. But what usually happens is somebody steps in as emergency POA, so they're responsible party, and that person can sign consent for them. Who signs consent doesn't matter to us. We just want to know that somebody is signing it. Remember that restraints are always, do they control behaviors? Yes. But we don't ever want to chart them as such. We don't ever want to chart them as if they are some type of punishment. It always needs to be for our patient's safety. Okay, so for a medical reason or for our patient's direct safety is the reasoning that we would put them into restraints. If we put a patient into restraints and that reasoning if it comes off as maybe this was the easy way out, or this could have been prevented, then that would be considered false imprisonment. And false imprisonment is obviously a type of abuse. So a very big deal there. Also, another thing to note is when we have a patient in restraints, regardless of what type of restraints those are, we are never going to tie those restraints to the bed rails, because obviously if I were to put those rails up or down, that would change the tightness and could injure my patient. So we're always tying them to the frame of the bed. So that way also the restraints are still movable. If there would be an emergency, if there would be a fire, I can still move that bed and my patient is not restrained or attached to something not on the bed. Okay, so I can still move them out of somewhere quickly. So the frame of the bed, it's the movable part of the bed. And the other thing that we're talking about while we're on the topic of fires, if there were a fire, we can go ahead and talk about that. This is something, I have an acronym that you guys need to know. Probably some of you have heard it before. They use it a lot in a lot of job trainings. If we ever were to get a question about fires on our test, on this test or a state test, we are always going to go with the acronym RACE, because whatever that question is, it's going to most likely ask about the sequence, about you walk in and there's a fire and what do you do next. So we're going to use the acronym RACE, and this is important for you guys to know. So that first letter R is for rescue. So if I walk into my facility and there is a fire in the dining room, I'm going to rescue all my patients by removing all of them from the dining room. Or if the fire is in the patient's room, I'm going to remove that patient from the room. And the next one is A. So A is for alarm. So I'm going to go and pull that fire alarm. C is for confine. So I'm going to confine the fire. So if that fire were in a common area, let's say the lobby or the dining room or whatever it might be, I'm going to close off the doors to that area, and then I'm also going to go and close the doors to all of my patients' rooms. So I've got nobody in the area where the fire is. I've got all my patients in their rooms safely, and I'm going to close their doors as well so that they are blocked by several doors from that fire. And then the fourth one is obviously extinguish, if you get to that point before the fire department were to show up. So rescue, alarm, confine, extinguish, and they need to go in that order. So if you had a question, you just walked into your facility, the charge nurse has just pulled the fire alarm, what is your next course of action? And it's going to be confine. Now I'm going to go count all of my patients and close all of their doors. Or you walk into a facility and all of the aides have just finished closing the doors. What is your next course of action? Now you're going to extinguish. You're going to grab that fire extinguisher and begin extinguishing. To go along with the acronym RACE, so rescue, alarm, confine, extinguish, to go along with that is the acronym PULL. And pull is if we were to ever get to where we had to use that fire extinguisher. So for pull, the P is going to be for, not pull, it's pass. Sorry guys. Yeah, pass, not pull. I hope you didn't write that down. So the P is going to be for pull. I'm going to pull the little like trigger thing that's on the fire extinguisher. A is going to be for aim, so I'm going to aim it at the base of the fire. S is for squeeze, squeeze the trigger, and the other S is for sweep. So I pull out the little key ring that keeps it locked, aim it at the base of the fire, and sweep it back and forth. So race and pass, those are both important for you to know. The next thing that I want to talk to you guys about is, let's talk a little bit about choking. So choking is a big deal. It's something that can happen often in nursing homes. I'm going to go grab Choking Charlie, and in this half of the video, the second half will be a lot shorter, hopefully, and I'll start it with Choking Charlie.